So, acute pancreatitis is a medical emergency, and I believe most of its differentials also include medical emergencies. In this presentation, we will discuss the definition of acute pancreatitis, its pathogenesis and etiologies, the clinical picture, and how to take the clinical picture in your diagnostic studies and funnel them into being able to properly and early on label the patient severity and determine their prognosis. The patients might have similar presentations in the very initial hours or even the initial hour, but then they have divergent paths. Some of them go on to continue to have mild pancreatitis, and the others might have life-threatening pancreatitis. And even if they end up surviving, they can have bad chronic sequelae. While we're not going to discuss chronic pancreatitis here, we are going to try to prevent the loss of function of the pancreas due to chronic inflammation and or destruction. So severity and prognosis will be discussed in an objective manner, and the treatment, as well as the non-pharmacologic component of the treatment, mainly in the form of when and how to reintroduce food and what kind of adjunctive therapies as well that we're going to add to our patient. The pancreas is a long, flat gland in the retroperitoneal area stuck behind the stomach in the upper abdomen, and its inflammation is termed pancreatitis. Now, the pancreatic function is to produce enzymes. Those are exocrine enzymes that go through ducts and they are secreted into the intestines, and they have no way of kind of invaginating between the cells outside the digestive system. However, when there is inflammation or damage, then they can do so and they can start auto-digesting the body. And they can also excrete hormones. Those hormones are in islet cells. Those include insulin and glucagon. And while they are just kind of sitting adjacent to the pancreatic duct and the exocrine function that kind of secretes itself into the intestines, well, when there's inflammation of the pancreas, you can destroy those islets as well, because now the whole area is inflamed. And that will also lead to not only being unable to digest your food, it'll also disrupt your ability to handle energy processes, such as that of the metabolism of glucose. Pancreatitis can occur as acute pancreatitis, meaning it appears suddenly and lasts for days. Or pancreatitis can occur as a chronic pancreatitis, which is pancreatitis that occurs over many years. So that usually will have flares of acute pancreatitis over time, but the hallmark will be loss of function. Mild cases of pancreatitis may go away without treatment, but severe cases can cause life-threatening complications. To me, whenever a patient has pancreatitis once, they are at higher risk of developing pancreatitis in the future. And if you ever have recurrent acute pancreatitis, that can also lead to chronic pancreatitis. So chronic pancreatitis, for many intents and purposes, is in fact a complication of the acute emergency. The pancreatic duct and acinar injury via direct or indirect toxicity. Toxicity is, of course, a possibility due to use of medications, abuse of drugs, recreational drug use, and, of course, surgical and external trauma are also possibilities that lead to pancreatitis. Furthermore, ischemia for any cause through the blood supply to the pancreas can also lead to pancreatitis. So those are some of the different causes. Other possibilities would be some inflammatory processes. So what happens is the moment that you start destroying the pancreatic tissue, this loss of parenchyma means that the digestive enzymes will lead to more damage. So it goes into this incredible vicious cycle. Let us assume that the cause of pancreatitis here was trauma, car accident, for example. The moment you have an accident to a tissue, now you suffer the damage and the inflammation and the edema and the chemotaxis and, all the inflammatory cascade. But in the pancreas, the digestive enzymes themselves will go on to cause an incredible cascade of autodigestion. and more inflammation. And that's why pancreatitis is a very serious illness. And notice its proximity to the liver, so it can cause irritation, inflammation to the liver capsule and the liver itself. Notice how it's tucked behind the abdomen. This whole area can become inflamed and edematous, and it can collect large amounts of fluid over there and cause the patient to go in shock, and that shock can be hypovolemic, and it can create rich area for infection, especially if any food particles are introduced while we have an actual sphincter here, the sphincter of Oddi. If the inflammation is in the head of the pancreas, then you can also have an infection. So for whatever cause there was an introduction of infectious pathogens, then that leads to more and more difficulty, that leads to more crisis in that area. In fact, of interest, this epigastric pain can be a differential of inferior myocardial infarction, and it's something to consider whenever you have someone with epigastric pain. And the truth is, it is not any less of an emergency at any level, especially in the severe cases. The only difference is some medical emergencies, when diagnosed, they're inherently emergent, like bacterial meningitis, like myocardial infarction, for example. But pancreas, the inherent severity and risk of mortality is related to its severity. So you see how we touched on the concept of severity a couple of times. So those are what acinar cells look like, and the ducts and the exocrine functional unit looks like in the pancreas. And that's a histopathologic sample. Look how smooth, how beautiful it is, and how the endothelial cells are lining the area and separating the cells from the acinar ducts. If that is disrupted for any reason, then you have digestive enzymes here that'll start eating away the cells themselves, and that causes inflammation. It causes chemotaxis, recruitment of more inflammatory cells, and more inflammation, more damage, and more inflammation until potentially there's a lot of loss. I want you to remember, if you look here, look how many enzymes the pancreas is responsible for. So amylase, trypsin, nucleases, lipase, and all of the pancreatic excrements are also basic, so they have direct corrosive effect when they are exposed to local tissues. So let's talk about the etiologies. In 40% of the cases, of course, this is USA statistics. This is the most common cause of pancreatitis. It's gallstones. It's more in females than it is in males, and it's usually due to smaller stones, the sub-centimetric ones. In fact, usually less than 5 millimeter. And we call those microlithiasis in sludge. Those can really stick anywhere along the pancreatic tree. So with imaging, you might not see anything, but in the smaller ducts, they're dislodged somewhere. In fact, they can even cause sphincter of Oddi dysfunction. We'll look at that now. The second most important one is alcohol use in 30%. In this case, males more than females. And the epidemiology suggests 4 to 5 drinks per day over 5 years. That causes the risk to be much higher. So ask specifically not only if you drink alcohol, but how much the patient drinks alcohol. And it's usually a cause of chronic pancreatitis with acute flare. So you're going to see the acute flare, but you know that chronic pancreatitis is a possibility. Remember, we said if you have one acute, you can have more, and therefore you can develop chronic. Well, you have a continuous cause of the inflammation, which is alcohol use, and so that is a common cause of chronic inflammation. Hypertriglyceridemia in itself can cause pancreatitis, especially type 1 and 5 familiar hyperlipidemia, and so is hypercalcemia, because that can also deposit as well as bind to fatty tissues. I'm not going to go in details about the pathophysiology of those, but you need to know that those need to be tested for properly and treated. And in fact, the hypertriglyceridemia cases, you need to have aggressive treatment in the acute state to the extent that you try to deplete the blood compartment from lipids, especially triglycerides, even if it meant putting the patient on plasmapheresis. So it's not a joke. Drugs, well, there are a lot of drugs. In fact, when you first interview a patient and they tell you, hey, doc, I'm a patient who has had an ischemic heart disease a long time ago, and I have a component of heart failure, and I take aspirin, and I take ACE inhibitors, and I take statins. So now you know that the risk is slightly higher. And if that patient is a lady who's taking oral contraceptive pills and who has, because she had an ischemic heart disease, she also has peripheral vascular disease or atrial fibrillation or arrhythmia secondary to the cardiac cause, which caused a brain insult. That brain insult caused her to have an epileptic disease, and so she's also taking valproate, then that means that her risk is higher. Maybe you interview this patient now, and in addition to those medications, she's taking something like aldactone, and she's fine. But then with time, her heart failure worsened, and now she had to take furosemide. And every now and then, she takes metronidazole because she has bacterial overgrowth syndrome because of her uncontrolled diabetes, and so it increases her risk of pancreatitis. I'm giving this kind of hypothetical because you need to get to know your patients and to expect what's going on. But also, when you're dealing with medications, it's much easier to kind of put them in scenarios and remember what they're used for. So when you know a diagnosis, you suspect that patient might be on a medication. So for example, someone who's taking isoniazid for tuberculosis, and in our society in the Middle East, we have a lot of patients who are tuberculous. And so that also should raise your suspicion. All right, so other medications include cytosine, didanosine, dapsone, pentamidine, tetracycline, and all the sulfa drugs. That's a large group of sulfa drugs. Someone with inflammatory bowel disease. Most of your antibacterial medications can have sulfa moieties, or at least half of them. So that's something to consider. And the 6-mercaptopurine and azathioprine are also medications that you need to consider. All right. So another etiology is an anatomic etiology, pancreatic divism. So let's look at this image. You see a normal pancreas is here. You have a singular pancreatic duct, and then branches coming off on each side that's collecting from the acini and emptying in a beautiful way through the sphincter of Oddi and the ampulla of Vater. In B, you have a classic pancreatic divism where you have one and then you have a smaller duct. And that duct is literally smaller, and so the plumbing there is not as good. And anywhere that you can have disruption of flow, you can potentially have obstruction, backflow, pressure, and pancreatitis. So if you look at C, and you have a magnified image here, which demonstrates the small communication between the dorsal and the ventral pancreatic duct systems. And so you have this kind of communication here. In D, this is called a reverse pancreatic divism, just because of the anatomic relation where the congenital duct is the one that is above, and then or the smaller duct is the one above. So you have to remember that the pancreatic divism happens in the womb when two parts of the embryo's pancreas, the ventral and the dorsal ducts, do not fuse together to form one main pancreatic duct. So pancreatic divism is in fact a wide disorder. It is pretty common. It affects 5 to 10% of the general population, but the vast majority of people don't have any symptoms, and you might not even know about the fact that they have this anomaly except and until an autopsy is done. However, obstruction and backflow, as we said, may lead to pancreatitis. An additional anatomic anomaly is pancreatic annular pancreas. This actually is the most common birth defect in the pancreas, and the term annular pancreas means that a ring of extra pancreatic tissue covers the duodenum. Again, that can cause plumbing issue, and so it can cause obstruction, backflow, sluggish flow, or slow emptying, and that can slowly irritate then when you have enough inflammation, and you can start having the cycle of autodigestion and autodestruction. Another anatomic etiology is duodenal duplication cysts. So if you look at this diagram, if you have any additional pressure on the pancreatic drainage system, then you can have potential issues. So this is a rare congenital anomaly of the GI tract. The other one is sphincter of Oddi dysfunction. So again, you have the ampulla, which is the opening. Behind it, there's a muscular apparatus known as the sphincter of Oddi that regulates the emptying of the pancreatic ducts. And sphincter of Oddi dysfunction refers to the medical condition that results from your inability to contract and relax the sphincter normally. There are multiple causes postulated. It's mostly an unknown cause, but the postulated causes are probably due to microlithiasis. And what it does is causes obstruction of bile flow, resulting in biliary pain, and obstruction to the flow of pancreatic juice, which can lead to pancreatitis. Other etiologies include autoimmune pancreatitis, which in itself is an entity. Autoimmune pancreatitis, known as AIP, is a chronic inflammation that is thought to be caused by the body's immune system attacking the pancreas, and that responds to steroid therapy. Luckily, there are two subtypes. There's type 1 and type 2. Type 1 is related to IgG4 related disease, and IgG4 related disease is actually abbreviated to like this, IgG4-RD. This is something that you should really read about if you're at all doing internal medicine or rheumatology or endocrinology. This disease often affects multiple organs, including the pancreas, bile duct, the liver, salivary gland, lymph nodes, and the kidneys. Type 2, on the other hand, is actually more specific to the pancreas. It's less likely to have other organ systems. However, 1/3 of patients have associated inflammatory bowel disease. When you start knowing those epidemiologic distributions of disease, then you can know how important, you start to understand, maybe even for some people, you start to understand for the first time why history taking is very important, because you can really start picking on a lot of the deductive reasoning and thinking modalities that can lead to a diagnosis, because you have risk inherent to, for example, having inflammatory bowel disease and coming in with acute pancreatitis. It might be type 2 autoimmune and the lack of other more common causes. Familial causes. So suspect of early onset below 20 years, and it can cause acute and chronic pancreatitis. And one of the familial processes is hyperlipidemia. Infections such as Ascaris, Clonorchis, Sinensis, that's the Chinese liver flu, and I'm not sure I'm pronouncing that right, Coxsackie virus, cytomegalovirus, Epstein-Barr virus, human immunodeficiency virus, mumps, mycoplasma, tuberculosis, toxoplasmosis. Those are all infections that can be the initial cause of pancreatitis, not a complication, because acute pancreatitis can have a complication of infection, usually a bacterial infection. Ischemia. So a systemic shock can mean that most organs are hypoperfused, including the pancreas, and so that causes ischemia. Vasculitis can cause local as well as systemic issues, and cholesterol emboli, even infective endocarditis, can cause a septic embolus, and that can cause ischemic pancreatitis. Neoplastic, pancreatic, ampullary tumors, especially the ones, so ampullary is definitely a cause of pancreatitis because it's going to obstruct flow of pancreatic fluid, and of course metastasis from other organ systems. Post-ERCP, that's endoscopic retrograde cholangiopancreatoscopy or pancreatography. So you use a scope and then you inject a dye and then you image with fluoroscopy, and that because you engage the ampulla of Vater and inject into the pancreatic duct, you can cause local inflammation. And so prophylaxis can be done with rectal indomethacin, which can decrease the symptoms, and temporary pancreatic duct stent can be placed in those patients who are suspected to have high chance of local inflammation and obstruction of the ampulla of Vater, and so you try to prevent that by placing a stent. Inflammation causes edema and narrowing. Trauma, blunt abdominal trauma, and Pancreatic or biliary surgery can also lead. So someone may have had a pancreatic tumor, and that tumor is not ampullary, for example, and it was not obstructing the flow for whatever reason, and they went on to have a surgery. It was removed, and because of the surgical removal, they develop pancreatitis afterwards. And of course, a more likely scenario is a surgery around the pancreas.